So very good morning to all of you. We welcome you to our IC on Intraoperative Surgical Twists, Managing the Unexpected. I'm Dr.Manpreet Kaur from RP Center, AIMS, New Delhi. My panel of instructors include Dr. J.S. Tityal, Dr. Samar Basak, Dr. Namrata Sharma, Dr. Samresh Srivastav, Dr. Sharon D'Souza, and Dr. Shreyas Ramamurthy. And we'll start with the first talk of the IC by Dr. Samresh Srivastav, Nucleus Management in Large PCR.
Hello. Yeah. Good morning, and thank you, Dr. Manpreet, for inviting me for this instruction course. So I'll be discussing very specifically on nucleus management in case a PCR happens, and I'll discuss this on a case-based scenario. So this is a patient. I just want you to notice that one of my fellow doctors was operating, and I was called into the OR when the situation was like this, and I could make out that there is an area of extreme clearing at the distal end. It's a temporal surgery, so at the nasal half something is cleared up big time. And this generally, technically, if you see things clearer, then you should be wary of a PCR happening. The goal of, as a doctor, when a situation like this arises, is to, number one, prevent any vitreoretinal traction. That's the number one thing we want. And then finally, we want to see if we can salvage the nucleus and not let it sink, but that's not our primary concern. The primary concern shifts gears the moment this happens. My approach in a situation like this has moved from limbal to pars plana vitrectomy, because if you do a limbal vitrectomy, generally you enlarge the PCR, and if you have a nucleus in the eye, the nucleus will tend to drop off because it's like a zipper-like opening, as you can see over here. On the other, so if you look at the limbal vitrectomy that I'm doing over here in an experiment in a high-speed photography, notice that the entire vitreous body moves upwards, and notice how these sharp edges of PCR will open up like a zip. And this is going to cause a problem to us more often than not. If you do a pars plana vitrectomy, which is with the nucleus in the eye, if you approach the eye from the vitreous from the behind, you will be able to probably save that PCR from enlarging, and then you can tackle the nucleus at a certain time. So again, high-speed photography showing very tranquil environment with a pars plana vitrectomy, which means the vitreous cutter is behind the posterior capsule. So going back to that case over there. First thing first, we need to visualize what's happening. So I use triamcinolone, and as you can see over here very clearly, on that part there is vitreous that's already presented. When you see a vitreous, your first commitment is to clear the vitreous. I use a trocar cannula system, but you can use an MVR knife to make a slit entry into the pars plana area for 3.54 millimeters, and then do a vitrectomy. And notice whatever vitreous had come anteriorly has collapsed back into the posterior compartment in the area of the PCR. If you try to tackle the nucleus before you do this, and when you rotate the nucleus, the vitreous strands will get adhered to the nucleus body, and then you will cause traction, and sometimes you'll be chewing up the vitreous, and sometimes you'll be chewing up the nucleus and causing peripheral traction. But if you do a pars plana, it will not happen. Once the pars plana vitrectomy is done, now I can handle the nucleus safely because nothing is intertwined. But notice what I'm doing over here. I'll just pause for a second to show you again. Is I've split the phaco into two. My left hand has the irrigation and my right hand has the phaco probe. So I'm using a bimanual irrigation to keep the fluid such that the nucleus doesn't go down, while I'm using a phacoemulsification to emulsify the area of the nucleus, the remaining nucleus. Because it's a temporal surgery, I have to emulsify distally, right in the area of the PCR. But I'm able to do that with lower parameters and the fact that I separated the fluidics, the irrigation, from the aspiration. It's important to do a pars plana vitrectomy because you want a stable scaffold in a situation like this to put a lens inside. Which means that if you do a limbal vitrectomy, you can only do so much to clear up. If you see over here, you can only clear up only so much space and not a lot of vitreous behind the PCR to call a stable scaffold. So vitreous what is remaining will tend to push the nucleus, sometimes the IOL, sometimes out of the bag, and sometimes it will decenter it. On the other hand, if you do a pars plana vitrectomy, you will be able to clear it off way beyond the area of the PCR, thus giving you a very stable place and a stable bag where you can place the lens and the lens will stay centered. One thing for certain is, if your nucleus falls down like this, The last thing you want to do is fish out the nucleus, because as you can see over here, the vitreous body and those vitreous strands are so entwined with this nucleus that if you pull something, you are most definitely going to cause peripheral retinal traction and tear. So this is just to show you that if you land up in a situation where things have dropped, I think it's best to let it go and to let your retina surgeon handle this situation rather than we trying to do a fish hook or pulling this nucleus out. One more case, it's a young patient, diabetic with bilateral posterior subcapsular cataracts. This is how the picture looks, probably a steroid cataract. Phacoemulsification is pretty straightforward in this, and I'm just going to move out of this. So we do a 4-quadrant technique for softer nuclei because sometimes it's very difficult to prolapse them. And that followed by removal. I'll just go back over here. So while we were doing a bimanual IA, we realized that the PCR has happened. When a PCR happens, again, if you notice over here, we've gone for, instead of a limbal vitrectomy, into a pars plana mode. So right now there's a whole heminucleus in the eye over here, but we are leaving it where it is, and we are cleaning off vitreous in the area of the PCR. Now I don't know the extent of the PCR, I don't know how big it is, what is the situation, but first I want to handle the vitreous body. Because if I don't do it, there is no way I'll be able to take out this nucleus en masse. Once I've done adequate vitrectomy and made sure that the area is clear and my anterior segment is clear of the vitreous, then I go ahead and I rotate the nucleus. And notice how I'm rotating it in the area of the PCR now, because I am certain that it's not going to drop or not get entangled with the vitreous. One more thing is always to do a bimanual. When you do an exchange of instruments, you use a dispersive viscoelastic. Now here again I have split my irrigation in my left hand and my phaco in my right hand, and I have prolapsed the entire nucleus out of the bag, and I'm doing an anterior segment phaco, but I'm keeping the irrigation. Again, if you notice, the IOP is 12, which means a bottle height of 50, and my flow rate is low. So I want to go slow when I eat. I don't want to chew up everything, and I want things visualized. And notice how big the PCR is. It's from edge to edge. There has been a split in the posterior capsule. And I'm keeping an eye, making sure nothing big falls down. But if it does, I'm not going to go and fish for it. I'm just going to let it pass. It's a compromised situation. So for me, the important goal is right now to maintain as much of the anatomy as possible. See if I can put in a lens, or if not, at least I don't do more damage than I already have done to the eye. But fortunately for me, the nucleus comes out quite comfortably. Bimanual IA, again, it's very important to use a bimanual over a coaxial, because it keeps control and keeps your bigger ports away, and to use lower parameters. So again, my IOP, which is my bottle height in a non-active fluidics, is about 40-45 centimeters, and my flow rate is actually 4. 4 flow rate means driving a car at 10 kilometers per hour when you're used to 60, because you want to make sure that you're pulling the cortex and not the vitreous, and you want to visualize what you do. Again, I've cut it off in the interest of time, but this is all viscoat. So when you do an exchange of instruments to change from right to left, please exchange with dispersive viscoelastic rather than yanking out your instruments, or the vitreous may present. So this patient had a toric lens that was to be implanted, but because I was certain that the vitreous has been tackled, I'm going and putting the toric lens in the capsular bag. It's very important, again, when you have a choice of lenses, to use a hydrophobic lens and use a lens that opens up slowly and gives you adequate time for you to assess and for you to position the lens. So I know there is an open capsule posteriorly, but because years of confidence and the fact that I know the material well, it's very, one can slowly but gently insert the lens. So I'm not dialing it or pushing it, but I'm using both instruments to slowly push the lens into place and to align it eventually into its desired axis. If there is the slightest doubt that it may not happen, it's best to leave it. And now the lens after that was captured through the anterior capsule. This is to show you the post-operative OCT. Macula looks okay. The lens is well centered, and it's an optic capture, which means the entire IOL is inside the capsular bag, but the haptics are out of the anterior capsule, lying anteriorly. And this is to show you patient at 3 months, fibrosis has set in, and the eye is quiet. So to conclude, if you land up in a situation where you have a PCR and you have a nucleus body in the eye, first handle the PCR. Visualize, use triamcinolone, use good cutters, clean the vitreous, because if something falls, the retina guy will take it out and the patient will see well. But if you try to fish it out so that you don't have to explain to the patient, you will have to do a lot of explaining for many, many months to come. So what's better is to do your job and just clear out the eye. Thank you.
So I have a question for Shamudesh, like, do you prefer 23 gauge or 25 gauge parts plane?
So I'm using the 23 gauge as of now. I don't think the Centurion is supporting a 25 gauge vitrectomy. And I'm doing a vitrectomy out of a Centurion anterior segment. I don't have a vitrectomy machine as in posterior segment, but I'm not sure if 25 gauge cutters are supported. I would love to do 25 support.
So next I invite Professor J.S. Tityal for premium mile implantation in PCR rescue techniques.
इसमें है
इसमें है सर आपका
तुम डाला मेरा प्रेजेंटेशन तुम डाला हुआ है I give you the pen drive, no?
Right. Good morning, everyone. And thank you very much to Dr. Manpreet for including me in this IC. It's an absolute pleasure. So I'm going to be talking about deep anterior lamellar keratoplasty, and just we'll be focusing more on what possible hurdles that we could have. So there is no doubting as to why we would prefer doing a lamellar keratoplasty. It definitely has a lot of advantages. However, it does have a slightly steeper learning curve than a full thickness penetrating keratoplasty. And the idea with DALK is, it's extremely logical as a surgery. And if you just understand the air dynamics, then it makes our lives much easier in trying to tackle these complications. So decision making is to look at the scar, and this is very, very important because you have to decide what technique of DALK you would do. And if you have a full thickness scar secondary to a high drops, not anything else, but secondary to a high drops, then you would definitely avoid doing a big bubble technique because you can have a break in the DM at that stage. And believe me, a very well done manual dissection will also give you very, very good results. It may be slightly slower in recovery, but the patient will definitely do well, and it's much better than converting to a full thickness keratoplasty. So understanding the scar and depth of scar is very, very important. And just because you have a high drops does not mean, a post-high drop scar does not mean that you'd have to directly go to a penetrating keratoplasty. You can still get away with doing a DALK. So this is a routine big bubble DALK surgery. I've already de-roofed and removed part of the anterior lamella. This was a very thin cornea, so I've left the cap at the thinnest part. And in this thing you see, we've just gone to a deeper level, put in the cannula, put in air, formed the big bubble, de-roofed it, and now we are doing the usual quadrant technique to try and remove. The only instrument which I think is absolutely very, very useful is a blunt tip scissors. So please make sure you invest in that. It's not at all expensive, but it does make our life very, very, much less stressful when we are doing the posterior dissection and very close to the DM endothelium complex. So at this point, one very important thing to remember is when we are using, irrespective of whether you're using a needle to make the big bubble or a cannula, you have to understand the location and the depth and the direction. Now, initially, it's a little difficult to assess the depth, especially with the needle, and the fear is always that we will be too superficial, and I'll be coming to how we can understand it. In releasing the bubble, there is our own set of challenges that we will face, and of course, the posterior dissection of the stroma. So let's deal with that subsequently. For a manual dissection, if you have to do the same step, you de-roof anteriorly and then go ahead. There are multiple techniques described, whether it's the groove and peel or directly go to a different level. But basically, it's the same thing. You just keep removing layers of stroma till you reach deep enough. And as you go posteriorly and closer to the DM, you'll find that there's almost like you can peel off the stroma, and that's your clue that you are very deep and need to be more careful. So the main point is that if you understand a few things about the surgery, it's easy to avoid complications. So one of the most simple, and this I can't really call a complication it's more of a hurdle, is that you just don't get the bubble at all and keep injecting into the stroma, and finally this happens where you want the air to go forwards. Stromal emphysema, or the bubble will come only if it's going forwards. If it's coming backwards, stop. And also, if you're having stromal emphysema, stop, because if you keep injecting, it will just become a diffuse entry. Last few things. One is, if you think you see air entering into the AC like this. And please understand that if it is coming in from the side, you see the bubbles entering in from the side, that is not a perforation. That is the air which has traveled around and come in through the trabecular meshwork. If it's coming right centrally, you see air in the AC where your needle is, that's a minor perforation. You can also get a lot of post-operative complications, even though rejection is very, very low. But there are a few things that can happen post-operatively, usually well handled. And I still say that wherever possible, please go ahead and do a lamellar keratoplasty. Thank you very much.
Thank you, Dr. Sharon. It was an excellent collection of cases. Now I invite Dr. Samar Basak for his talk on endothelial keratoplasty challenges, vanishing scrolls and rolls and lenticules.
Manpreet, for including me in your courses. No, not come. Laga do. So, I'll be showing two different scenarios in endothelial keratoplasty. One is the vanishing lenticule and another is vanishing demacrole, and how we have rescued it. So, these both the cases are in post-VR surgery with SFIOL. You know that EK in post-VR surgery is always a challenge, especially in presence of SFIOL. The globes tends to collapse after making the incision, and in DMAC, inferior PI is often difficult. Donor transfer is also a problem, especially in presence of large iris defect, and because the AC behaves differently. And even after injecting the lenticule or roll, the globes tend to collapse, and there is a tendency of creating negative suction within the vitreous cavity, and this results twist during the surgery. So I'll share two cases. One is vanishing dissect lenticule and rescue, and second was a vanishing demacrole and rescue. The first was done by Shoham, and it is just, you cannot redo it. It just happened, and rescue is happened as accidentally. So you know that we have described AR-assisted donor lenticle insertion in presence of huge iris defect, especially for aphakia or SEIOL with large iris defect, because it is often challenging, AR tamponade is difficult, and graft might get posteriorly. So we have published this, and this is the original method. You see that in presence of AR, this only the thing is that you have to give a larger main incision, and with a needle 26 with bend nibble, there is no AR escape, and you go right at the back surface of the cornea and then put suture, and this usually do well in our hand, and we have already done more than 50 such cases. But this is the case. I will showing where the problem happened. There is a SFIOL, and you see the iris defect is there, and the surgeon was Shoham, and as usual the AR injection is given, and in this case always it is preferable to do the thing, and surprisingly it opens in right direction. So you probably can never do it again. It is just accidental rescue of this thing, and then usually you put sutures and give sufficient AR tamponade, and this patient, you see that after all this manipulation, this patient is doing good, 624 vision with 1300 cell count and all. This is the vanishing, this is my old video, vanishing Dimecrol and rescue. This is again a case of this thing post BR with SFIOL, and you see that I didn't know history was got from the patient, that PR surgery, old patient. I did during PI, I realized that there is actually IOP is so low. So while going in, I was just tapping over the, that time I didn't have much experience actually. You see that I was tapping and it was going inside the pupil. I didn't realize that it goes inside the pupil. So it is definitely behind the iris. I try to locate it, and then I try to feel it with a Sinski, whether it is there or not. Then I tried with McPherson. First time it was miss. Second time I could catch it. The DMAC roll is there. So I take it forward into the anterior chamber and then take the whole graft into the anterior chamber. This time I was very careful and I was slow in tapping and sweeping movement, and then with little tap from the periphery I could open the graft. And you see that S mark is visible now. Only the centering is now is to do. S is visible in lower part in towards 6 o'clock position. And then I put here. So this is the end of surgery. And this patient did well after. This is post-op day 4, 660 vision. And this is post-op 1 month with 612 vision with a good cell count. So be careful while performing EK in post-VR surgery. That is the take-home message. Thank you very much for your patience, Eric. If you have any question, I can take questions.
PR cases, because you don't have a support from behind, wanted to have, like somebody showed us, Pastelina infusion, which will keep the pressure up always.
We have not done it, but one thing we used to follow here, Shom, is that we always put a suture in the lenticle, so that if it falls, that suture you can take it out, even in case of aphakia or in presence or absence of oil. So that was not done in this case. But we never had that increasing that. But usually those fluid use tends to come out because your wound is very large here. So possibly it is, but when you tap, the fluids tends to come out. Nowadays, what we prefer that in DMEC especially, we take older patient donor, older donor graft, so half open, it is always half open. So you need not to tap it more. So once you go in and you see the orientation, you can sweep it on lateral movement, and so you do not have to tap again. And I have seen the video that donor lenticle, DMEC roll goes inside. In one of my case, the donor lenticle goes inside the vitreous. I didn't disturb it. I put a dissect lenticle in that case, and I checked with the VR colleague, where is that DMEC roll? It was stuck to one side of the retina, so near the pars plana region. So it was not causing any hampering, so I said, no, don't touch it. Let it be like that. Thank you, Manpreet.
Thank you, sir. I now invite Professor J.S. Tityal for his talk on premium implantation in PCR rescue techniques.
Yeah. This is
इसको ऑन करना बेटा. Good morning, friends, and thank you, Dr. Manpreet, for including me in this particular instruction course, which seems to be a really, very nice, challenging situation being placed in all different types of intraocular surgeries. So I'm going to take you to one of my patients who had undergone trifocal lens in the other eye, and this is the second eye where I'm trying to do a femtosecond assisted cataract surgery with trifocal toric implantation. So once you have other eye already undergone surgery like that, then you are still have to do a good surgery. I've completed my nucleus emulsification, putting the trifocal IOL. I had a little cortex left in this particular corner. I thought I'll aspirate that. But while aspirating, I tore the entire capsule here. There's a large capsular tear. My lens is inside now, and the challenge here is now you can't take out this lens and replace with other lens, because trifocal lenses are not there in a three-piece design. So we have to manage this lens inside itself. Luckily, this is just a torn, posterior capsule. So we can still tamponade the tear and the anterior vitreous face. And the idea is to get this lens reverse anterior capture. So I'm injecting dispersive viscoelastic underneath the IOL surface so that I have a tamponade, give a space from both sides, use this biminal technique. After I inject the dispersive viscoelastic, I have to lift the lens over the anterior capsule, which I did here. So this biminal technique is very, very simple to lift the optics in front. You can see now, you can see the entire optics is up. This much optics up, and this optic haptic junction is inside the capsular axis margin. So this capsule will make things absolutely appropriate. Luckily, this particular case had the axis almost 180 degrees, and my lens was there when the tear happened. If the tear would have happened, if the position would have been like this, then it would have been very difficult to rotate. You may have disrupted the tear and the vitreous face also. And the challenge was to have this centration of this optics, as well as the axis should be centered well in this case. Luckily, I could achieve this. So this is one way of handling the cases with reverse optic capture. So this is another case where lens is inside here, and toric lens. And actually, I was doing a visco aspiration and tore the posterior capsule here. Again, this lens has to be aligned. So what to do now? I came out, thought let's again inject a little dispersive viscoelastic to tamponade this tear so that vitreous doesn't come out. And this dispersive viscoelastic is a very good agent you should have always in your table, and put the lens in a place. Now this lens has to be rotated almost 180 degrees to come to this particular axis. I could take out the viscoelastic from over the lens and keep the lens in the axis also. So these are two situations where you can have a difficulty also. This is a third case where I was aspirating the cortex, and you can see a large tear happen in this particular case. You can see a tear extending from the periphery to periphery, like Dr. Samresh showed earlier. Here again the viscoelastic tamponade is being done. Luckily here now the situation is different. I will outside. The few precautions I am taking here, I'll go a little back here. One is tamponading the anterior vitreous face with the dispersive viscoelastic. Second, I'll enlarge the incision little bigger, maybe 2.4, and get my nozzle right up to here so that my lens opens over the rexus margin, doesn't go into a vitreous cavity. So it is not wound assisted, it is inside the anterior chamber. Open the lens over the surface of iris, then gently tuck the lens underneath, and now manipulate the haptics into the rexus, inside the rexus, both ways. In that way, both the rexus are inside. Now I'll do an optic capture of this lens also. So whenever you have an open PC, you can still do it if you can put a interface with the dispersive viscoelastic. So this is the same case next day with the reverse optic capture. We had a good visual acuity in these patients. So I have shown you two stages of rupture. One, once your lens is inside the anterior chamber, inside the bag, only thing you have to do is tamponade the vitreous face and the tear and get a reverse optic capture. This is what I had done. Second is put the lens over the rexus margin then gently tuck the haptics inside the bag. In that way, your haptics will be safely in the bag, and you can again do a reverse optic capture in this situation also. Yes, if you have tears which is too large, where you have to do a vitrectomy in your cases, then naturally you can't retain these lenses in such cases also. So this situation is only applicable when you have an intact vitreous face. If you have a situation like this, the tear has gone so big, my rexis is also not appropriate here, lens is not getting stable, it's better to shift to a 3-piece lens and implant. The only problem in such cases is you have promised for a premium lens there, and you cannot implant, and you have changed your surgical modalities or technique. The patient has to be informed that this has happened, but we have managed the case appropriately. I think counseling the patient and the relatives immediately after surgery is very important, where you shift your surgical plan. Though you have done a good job for a patient, next day patient will be much more comfortable because the vision is going to be quite okay because you have managed very nicely. But the things which you have done, which you have changed during your surgical planning, has to be informed to the patient. I think that is one important thing we must learn in any surgical area where your planning has changed, your modalities have changed. The counseling becomes a very important part here. So you have to pick the happening as soon as possible, then take a measures to prevent further complications. Thank you for kind listening.
Thank you, sir. Wonderful collection of cases. You made it seem so easy, but I am sure all of us will have having our hearts in the mouth if we try this. Now I invite Professor Namrata Sharma for a talk on LASIK flaps gone astray.
In the meantime, if any questions or suggestions from the house, because you people all do these difficult situations, you create and then solve the problem, Shreyas, any comment?
Sir,
She's there. Okay, she's there.
it's okay. So, thank you, Manpreet, for this wonderful course and for making me a part of it. I would be talking to you about LASIK flaps gone astray. There are no financial or proprietary interests, and the flaps could be after microkeratome LASIK or femtosecond LASIK both. And you can have problems such as buttonhole flaps, such as this, and these are the buttonhole flaps after microkeratome LASIK. So once you have this, it is best to put it back again and to irrigate it with the help of the fluid and put a bandage contact lens on it. This is the second one where the buttonhole flap is present right in the center here. So again, you have to just put it back in position. And this is the third one, which is a post-PK LASIK, where there's a Z-shaped buttonhole flap. And in these cases, it occurs more because the corneas are really steep. Now, then you can have a thin irregular, or whenever you have a thin irregular or buttonhole flap, you have to defer the surgery and recut after 3 months. If the refractive error allows you, you can do subepithelial PRK. But if it doesn't, then you will have to recut at a deeper plane and a larger flap if you're using a microkeratome, and a smaller one at a deeper cut if you're using a femtosecond laser. Then sometimes you can have epithelial ingrowth in these buttonhole flaps, which have to be addressed by PRK. And microkeratome jamming can be caused by motor jamming, suction loss, drape slashes, loose epithelium, and precipitated salt of irrigating solution. And whenever there is a torn flap, then you have to see at what level the tear is present. If it is peripheral, you can proceed with the ablation after protecting the hinge. If it is mid-peripheral or central, then one has to reposit the flap back and recut at a larger diameter and at a greater depth. So this is a case in which there was a tear which was present in the periphery, so one could still do the laser and then put the flap back. The only thing is, in the post-op period, one has to be careful that there is no epithelial ingrowth from the area of the tear, and also that there is no diffuse lamellar keratitis, which can occur in these cases more as compared to the other cases. And you can have a dislodged flap also, such as this. Now, in very flat corneas, you can have free caps. And if the free cap is lost, then allow for central epithelialization and defer surgery so that there's some refractive stability. But if it is retrievable and it is greater than the size of the optic zone, then one can laser and reposit the flap back, and it may require additional amount of suturing, or you can leave it like this depending upon the degree of edema of the flap. But if the free cap is less than the optical zone size, then one has to defer surgery. So this is a case in which there was a free cap which was present, so the laser ablation was still done, the free cap was retrieved, and it was placed in position. And because the earlier marks are already present, so basically what you have to do is align them into the previous marks, and then subsequently place a bandage contact lens over it. I like to place it in the reverse manner because it kind of gives a better fit rather than putting it in the correct side up. Then this is our publication, Refractive Outcomes of LASIK After Flap Complications, and we didn't find any difference in terms of the visual acuity between the two groups where complications occur and where they did not occur. Then in cases of RK flaps, these incisions may just give way, and there may be separation of these incisions as you are putting the flap back. But these cases also can be ablated and the flap can be put back, again taking care that there is no epithelial ingrowth through the RK incisions. And this is our publication on LASIK for refractive errors following RK. Then complications can occur with femtosecond laser flap also, and such as in this case, notice that there is an opaque bubble layer, plus there are air bubbles which are present in the anterior chamber. So in these cases, what is done is that you can put the tracker off and you can still go ahead and do the laser ablation, because it will take time for the bubbles to disappear. Then there can be vertical gas breakthrough such as this, and in these cases it is best to plan the surgery at a later date. So one can see that there is a opaque bubble layer and a vertical gas breakthrough which is occurring. When the suction breaks, then you can have an incomplete flap. The lamellar bed treatment, if it has been completed and no side cut, then the procedure can be completed immediately. But if it occurs while making the side cut, then don't lift the flap and retreat later with a smaller flap at a greater depth. And the surface ablation can be done rarely if your refractive error allows you. Now, this was a case in which there was suction loss and the surgeon still went ahead with the creation of the flap, which should not have been done because the suction is already lost. And once you do that, you will have a flap which is oval, and then subsequently a repeat surgery was done 3 months later, so that now the flap is of correct dimension and correct morphology, and this is then elevated, followed by the laser ablation, and then putting the flap back. Now this is the same case in the post-op period, so you will have these two peripheral spindle will be present because of the previous flap and the flap which has now been created. This OBL I have already talked about. Ever since the hinge size has been decreased, the chances of this has become much less. This is a OBL which is present, and sometimes you can get away with this OBL also and do the laser ablation because the part of the pupil is still clear and it doesn't significantly affect your visual results. Then there can be micro adhesions or adhesions, especially when you're doing thin flap, then the adhesions may not separate very easily. So you put a blob of fluid over there, and once you put the fluid, then it will separate in a more amicable manner. So to conclude, the complications do occur after microkeratoma and femtosecond LASIK, but they should be diagnosed timely and managed appropriately. Thank you very much for your kind attention.
Thank you, Dr. Namrata, for showing a wonderful videos which are not seen nowadays much often. Just one query, in femtosecond laser we do have some unique complications like intracameral bubble, or you have anterior breakthrough. So, do you had some instances like that, and how are those managed?
So if you have air bubble in the anterior chamber, then it is best to put the tracker off and still go ahead with the ablation, because the air bubbles will take a lot of time to disappear and your tracker will not track because the pupil is not going to be absolutely black in color. And in case there is a breakthrough, then it is best to not complete the procedure And in case you've even completed the flap, it is best to defer the surgery to a later date.
Same like a buttonhole, you know. Thank you, Namrata,
Thank
for
you,
a
sir.
wonderful presentation. Now we shift to the chief instructor of this course, Dr. Manpreet Kaur from RP Center, because there are so many Manpreet Kaur nowadays in ophthalmology. So she's from RP Center, AIMS, New Delhi. And she's going to talk about the problems faced, especially in a smile suction loss and how to manage.
Thank you, sir. So I'll be talking about when it's difficult to smile, suction loss and retained lenticule. There are no financial disclosures. So smile is, of course, as we all know, surgically challenging as compared to flap-based corneal ablation procedures, and lenticule dissection and extraction happens to be the most challenging step. So the process of docking, it's a soft docking interface which curvates the cornea rather than applanates it. So a low pressure suction cone generates 35 millimeter of mercury pressure at the interface with a maximum IOP rise of 30 to 80 mm, and there is a longer suction time of 25 to 28 seconds. So the incidence of suction loss may be as high as 11% for novice surgeons. So how do you manage a suction loss? You have to, of course, identify the underlying cause and the stage of suction loss. So less than 10% of lenticule cut, you are safe, you can redock and restart the procedure. More than 10% of lenticule cut is where the real challenge lies, because there is no rescue mode to just restart the procedure from that point, and you have to convert to a surface ablation or LASIK at the same or later setting. Lenticule side cut, cap cut and cap side cut are relatively easier to manage. You can redock and repeat from the stage at which the suction loss occurred by gently altering the lenticule diameter and the cap diameter based on the stage at which the suction loss occurred. So this is a case in which excessive movements by the patient led to suction loss after 2.81 mm of the lenticule cut had been completed. So off note, just keep a look in the periphery. As you can see, the conjunctiva had come. So it's better to stop rather than continue pressing the foot pedal, because managing this suction loss is much more challenging than had you had to redock and just do the procedure again. So retreatment after 3 months, a nasal hinge based femtosecond LASIK was done, because more than 10% lenticule cut, you cannot really go ahead with a smile. This is a second case in which docking was uneventful. Again, for beginners, for all surgeons, you should keep a look in the periphery. As you can see, the suction loss is now imminent. Stop now rather than misfiring the laser. So this has occurred at the stage of cap cut. So there is a rescue mode present in the machine itself. At this point, you can redock and restart from the stage of cap cut only. So we just clean the interface, redock, use the OBL as an aid to centration, because you cannot really see the pupil now. So this OBL where we had started with the cap cut is used as an aid to centration. So some people advocate waiting a couple of hours for the OBL to disappear. I think immediate redocking is much better. The lenticule is then created uneventfully. Of course, you have to counsel the patient not to move again. 2 suction losses will be very, very challenging to manage. So lenticule dissection and extraction is uneventful. You do have more micro adhesions and slight difficulty in dissection, otherwise it goes well enough. Difficult lenticule dissection is the bane of all beginners with refractive lenticule extraction. Sometimes you dissect the anterior plane first, as is convention, and you just cannot find the posterior plane when you are beginning. More commonly, when you dissect the posterior plane first, you have a cap lenticular adhesion, and this is when you face a challenge in identifying and dissecting the anterior plane, and forceful dissection and an attempt to identify the plane lead to retained lenticule, delayed visual recovery, cap and side cut tears, posterior stromal damage, epithelial defects and irregular astigmatism. Prevention, of course, is better than cure. So we have described the meniscus sign to identify the lenticule edge in smile. So what you do is you just delineate the anterior and posterior channels, and while you are delineating the posterior channel in the beginning, just push the lenticule gently away from yourself and you see a meniscus shaped gap. So if the instrument is below in the posterior plane, this meniscus will be seen clearly, and while you are in the anterior plane, of course the meniscus will not be prominently visible. So this has helped us to diagnose misdirected entry before we have ended up with a cap lenticular adhesion. Sometimes you will end up with a cap lenticular adhesion despite the best of your intentions. So AIOCT can help as a rescue tool. You can see here that the posterior plane has been dissected and the anterior has been not. So just go in with a blunt tipped instrument like a Sinsky, a fine instrument. Gently try to nudge off the lenticule from the overlying cap. So your direction is reversed, and if you can identify a meniscus gap, the lenticule is peeling off, you of course know that it's been stuck to the cap, and then you can gently peel it off. So this is a case in which there was a cap lenticular adhesion. So as I gently peel off, I know that the lenticule is stuck to the cap. Just delineate an anterior channel. Detection is more important than the subsequent management, because once you know that this is the plane you have to go into, subsequent dissection is easy. So it's more of it's all in the mind, and the fear that we had earlier with cap lenticular adhesion does not remain now. Even if we end up dissecting posteriorly first, we are very confident that the lenticle will come out with ease, even without a forceps, as in this case. It just gently, smoothly slides out. You just have to know where you are and where you have to go next. So it's a potential surgical nightmare if not managed properly. Of course, you can end up with cap tears, side cut tears, stromal damage, and retained lenticle fragments. But if you know which plane you are in, you can manage it properly. So we have also described the double crescentic edge separation for management of cap lenticular adhesion. More difficult to manage than a completely retained lenticule inability to find a plane is a retained lenticule fragment. So sometimes when your dissection is not complete and you still try to take out the lenticule with the forceps, you can end up with a retained fragment. So you can see the stress line over here. You should ideally stop and dissect. So these retained lenticule fragments are very difficult to fish out. Triamcinolone has been described to aid in the visualization and take them out, but they do end up causing irregular astigmatism. Customized surface ablation may be planned, but the visual quality and the higher order aberrations are not going to be as good as in a clean case. So stepwise management algorithm for difficult identification of correct dissection plane in SMILE has been described by us, in which you just eliminate the options sequentially, and if you are still stuck, abandon the surgery and retreat at a later date and call for help rather than damaging the stroma. Cap tears and side cut tears almost ubiquitously occur when you are initially starting out with SMILE. If they are not involving the visual axis, the cap tears can be managed with BCL and lubricants quite well with no long-term adverse visual impacts. Side cut tears do not really affect the visual acuity. However, you don't really want to end up with a half flap when you were aiming for a cap. So initially our thinking was that you should have a patient selection of higher magnitude of refractive errors when you're beginning. With time we have realized that the edge is going to be 15 to 20 microns only. The lenticule may be thicker and thinner, so manipulations, you may have a tactile feel better in a 4 diopter than a 2 diopter, but you have to identify the lenticule edge, which the process is going to be same if it's a higher magnitude of refractive error or lesser. So avoiding low refractive errors is not really going to help you refine your technique that much. Microscope integrated IOCT is another useful guide in SMILE in which you can see in real time the interfaces. So just to sum up, the initial learning curve is surgically challenging. During laser application, you can have suction loss, black spots and opaque bubble layer. During lenticule dissection, you can have a misdissection, cap lenticular adhesion, cap and side cut tears and retained lenticule and fragments. Prevention is better than cure. However, complications are inevitable, and timely detection and management will give both the patient and the surgeon a reason to smile. Thank you for a patient hearing.
Thank you, Dr. Manpreet, for showing us such a wonderful videos, managing those complications so nicely. In the meantime, we'd like to invite Dr. Suresh to put up his presentation. Dr. Manpreet, now we have so many, lenticule-based platforms has come up. Would these complications be similar in those cases also, like especially suction loss?
So since their suction time is much less, it's expected that it will be less, the incidence, and even with Visumax Pro, these are the 500 cases. With 800, the suction time is reduced to less than 10 seconds. So the incidence of suction loss is expected to go down.
Like now you are experienced in a SMILE surgery. Do you think the suction loss is still a challenge?
Not really.
I think that's a very important point, Once you graduate into this surgery, the complication rate is hardly any in these procedures. So you really don't have to worry about complication, because if they are there also, they can be managed very effectively. Thank you, Dr. Manpreet. Let's have the, faking I will,
Yes.
I think I'll say dynamics inside the, anterior chamber with these lenses. Dr. Suresh Ramamurthy, and he is the dynamic person doing a lot of surgeries from, entire south, north, you can imagine, and he is a very good teacher for all of us. Dr. Suresh, please.
Thank you so much, sir, for your kind words, and thank you, Dr. Manpreet, for including me in the course. Phakic IOL surgery is possibly the simplest surgery that any anterior segment surgeon can perform. However, there are small situations where we can run into trouble, and I'm trying to highlight some of these challenges. The first and most common thing that we can have, especially with ICL, is that there can be a small tendency to reverse. So when that happens, essentially even when you're almost halfway in, you can stop, and after you stop, you can take a small, before you continue pushes inside, you still have full control over the lens, and you can rotate and twist your hand to bring it back into the right position. And you can also use the second instrument to slightly, once this has been, now I've tilted it and it has come halfway, and I can just push it, tap it on this side, and then it flips. So if it has, of course, opened completely in the opposite direction, it's better to remove it and then implant it again. But in these cases, when you're able to twist it and make it halfway right, you can just nudge it, and these patients do quite well. One thing we must remember is these are hydrophilic material. Even a little touch on the cornea will produce corneal edema. So it's important that you are very conscious of that, and if you are even running into any trouble, don't hesitate to remove the lens and implant it again.
Sir, just to stop. Like suppose you're doing a hydro implantation, like many people are propagating that. Can you do the similar manipulation in those cases also? Or opening will be faster than the viscoelastic use?
The thing is, sir, if with the hydro, the opening, yes, can be faster, but the other small challenge is that the jet from the hydro itself reduces our ability to control as compared to the second instrument in a viscoelastic filled eye. So that's the small challenge with hydro implantation. However, with the Indian lenses like the iCryl or the IPCL, because of the way the butterfly cartridge is, it's very, very rare that it flips. With ICL, while pulling the lens forward, if we are not perfectly parallel, we may end up slightly tilting the lens one side or the other, but seldom happens with the Indian lenses.
Yeah, thank you.
Yes, sir. The other challenge which we can have is really the variable vault, that we can have a low vault or a high vault. Now again, unlike a toric IOL, a toric phakic IOL almost never rotates. I mean, if you have, unless there's some parallax error, if you have implanted it in the right side, it does not rotate. So if it is rotating, we must be very conscious that whether this is a small lens for that eye. Sometimes your vault may be adequate. You may have a 300 micron vault, still the lens may be rotating, and this is essentially because for that particular sulcus, this lens is not adequate, and in those cases, or if you have a low vault on AIOCT preoperatively itself, we have measured, then no point in rotating these lenses. It's better to go ahead and exchange them. So exchange again is very simple. So all that we have to do is just basically the reverse and just dilate the pupil adequately. And this is a slightly older lens, so I'm making the incision again. You just keep one haptic pull, one haptic up, and use a hand over hand technique. Just pull one side and then use the other forceps and take it out. It comes out very easily through the same 2.8 incision which you have used for the original implantation, and then you can go ahead with the subsequent implant and use a slightly larger lens and achieve an adequate vault. Again, if it's a low vault or it's the older lenses where you didn't have the central hole, then you can develop an anterior subcapsular cataract over time. So just stain these lenses, because some of these capsules can be a little more fibrotic. So the rhexis can be a little more challenging than in a normal video. Again, removing it is very easy. This is I'm showing this that you can use a smaller forceps to initially grasp it and bring it out, and then a hand over hand technique with a larger forceps make it a lot more elegant. The rhexis is the only part which you need to be conscious about. Otherwise, it's usually a soft cataract and it's a very simple surgery. High vault is the bigger challenge, and these are pain. You have to remove the lens immediately. There are patients with a 1,100 micron vault where the ACD is quite adequate. The periphery angles are still open, and you can safely observe these patients without any difficulty. But in case of keratoconus patients, because of the central cornea being steeper, you may end up having a falsely higher central anterior chamber depth. Anterior chamber depth measurement is right, but for that particular eye, we would end up choosing a larger lens than what we would have chosen if the patient did not have a steep cornea. This can happen even with, I've had with patients who have high astigmatism as well, regular corneas with very high astigmatism, as well as with keratoconic patients, where you can end up having a high vault which leads to a optic capture. It keeps tending to capture through the optic, and this can become a challenge. This leads to lens tilt and therefore reduces the quality of vision. So again, you'll have to here exchange with a smaller lens. We've done a comparative study where we have looked at patients with centered as well as decentered cones, low and high astigmatism, and as long as the patient has a very good best spectacle corrected visual acuity, this is an excellent option in keratoconus patients. But the only thing that we need to keep in mind is remember that the sizing ideally should be one size lower than what you would select for a similar patient, especially when the Kmax is exceeding 50. If it's a very early keratoconus, 46, 48, you can probably go ahead with the same sizing. But anything beyond 50, just go one size lower, and these patients will do adequately, very well. And we know with the centroflow lenses, even if you have a vault of 250, 300, it's perfectly fine, and they do very well in the long term. Again, iatrogenic keratectasia is another indication where you can use these lenses. In any of these procedures, whether it is keratoconus or post-LASIK ectasia, you can first regularize the cornea either using intracorneal ring segment, improve the best spectacle corrected visual acuity, or you could even do a topography guided regularization. This is one such patient whose pre-op BCVA was only 618, but post topo guided treatment it improved to 6.9. And these patients, once they are happy and comfortable with the spectacle corrected visual acuity, and many of these have a significant anisometropia also, wherein one eye is a very early ectasia, other eye is a more advanced ectasia. They are unable to wear spectacles because of the higher degree of anisometropia. In these situations, a phakic IOL is an excellent option. Again, one other example, little more advanced keratoconus, where the vision improved significantly after intracorneal ring segment. The cone was much more central, much more repeatable readings, repeatable subjective refraction, and these patients do extremely well even later. Again, you can use it post-DALK as well. I would not want to use it post-penetrating keratoplasty, but post-DALK, this can be a very good option after all the sutures are out and your refraction has been stable for quite some time. You can then go ahead and correct the residual refractive error with a phakic IOL. And again, you get fairly consistent and repeatable results. And the only thing which we need to keep in mind is don't go with the topographic astigmatism because that can be a little more challenging. Go ahead with the subjective axis, use the subjective refraction when you have a repeatable subjective refraction. And I always give a glass trial, never go ahead with the phakic IOL directly. Ensure that the patient is comfortable with the best spectacle corrected visual acuity, because that is really what you are going to correct with the phakic IOL. You can also use it in pseudophakic eye, where either because of extremes of ametropia, you don't have IOLs of that power and the patient has a residual error, or there is a biometric error which has happened. It's a simpler procedure than exchanging the lens, especially if the capsule is already fibrous and it's been some time since the surgery has been done. And this can essentially being used as a add-on lens or a sulcoflex lens, where you're basically using a phakic IOL to correct the residual power. And again, these patients also do very well. The calculation is very simple, and you can just go ahead and implant the lens for the residual refractive error. Again, being a pseudophakic eye, the anterior chamber depth is usually very deep, and vault and other issues are really not there. And again, since these lenses are essentially hydrophilic material, if you have a hydrophobic lens in the back, bag, it really makes no challenges. These are again not situations which we encounter too commonly now, but in case you have a patient with an anterior iris clip lens which has been done earlier, and we know that some of these patients progressively the specular count keeps reducing. So rather than waiting for decompensation to happen and then doing a surgery, it's better to preemptively remove these lenses and exchange with a posterior chamber phakic IOL. And we have a few of these cases, old patients who are on serial follow-up. We see that the specular count is dropping. Then you go ahead with the ICL, and then the count subsequently stabilizes and you don't have any further drops. I'll just end with this quick video. Again, we operate mostly on very high myopes in these situations, and both the corneal as well as the scleral rigidity can be low. And as you can see here, this brittle cornea, though not a very common situation, the incision is tending to extend on both sides. Even the side port as well as the main port is tending to enlarge. So just inject the lens. All we have to do is be calm, suture the port, and then subsequently you can go ahead. And despite this challenge, this patient did quite well. But this is something to be aware of. This patient had fairly normal corneal thickness, no other abnormality on topography. But being a high myope, it is just that this patient can be associated with a brittle cornea and a lower corneal rigidity. This is one rare situation which can happen with even with phakic IOL patients, more difficult to address because doing a pupilloplasty in such eyes where already there is a crystalline lens and a phakic IOL becomes quite challenging. Some patients, when they come with a slightly more intense inflammation, these are young patients, and if they have more pigment dispersion in the initial period and are coming with this slightly higher amount of inflammation, increase the steroids, but I would say let's to avoid a cycloplegic or avoid giving homide, because sometimes they end up with this mid-dilated fixed pupil after that cycloplegic has been used. Thank you so much for your kind attention. Thank you, sir.
Thank you, Shreyas, for showing such a wonderful application of phakic IOLs and challenging situation also. Just for remembering my early days. One of the first ICL meet happened in 2004 in UK, and there was one surgeon from Russia for a very high bolt. He prolapsed the lens in the anterior chamber. He cut the haptics, the flanges, and implanted the lens back again to. Would that be a good option rather than exchanging the lens?
I think rotational stability would be very questionable. Maybe a spherical lens could be considered, sir. But in a toric lens, I think we'll better to explant and reimplant.
Maybe I think 20 years back that was the only option people had. But he rightly showed you have so many options, and these lenses are very safe and give you a very nice optical quality also. Thank you, Shreyas.
Thank you, sir. Thank you so much.
Any questions from the house?
Can we have all the presenters for a group photo? You guys there?